Okay, it's 5:31. Good evening to everyone who's joining us for our Seven Sterling webinar series designed to give you, healthcare providers across specialties, pearls to help you feel more confident in supporting your patients with mood and anxiety disorders across the lifespan of women's health. My name is Nazanin Homaithar, and I'm a practicing OB-GYN in Northern Virginia and the medical director at Seven Sterling. Seven Starling is a virtual mental health clinic that treats those experiencing anxiety, depression, and trauma throughout fertility challenges, pregnancy loss and miscarriage, abortion, and postpartum. I'm thrilled as always to be joined by Dr. Crystal Clark, Associate Professor of Psychiatry at the University of Toronto and Associate Head of Research at Women's College Hospital. She's dedicated her career to reproductive psychiatry and the advancement of maternal mental health as a researcher, educator, clinician, and thought leader, and also as an advisor to Seven Starling. We are lucky to be speaking to one of the leading researchers in the field of bipolar disorder in women for today's webinar. And I hope you'll be able to take away a better understanding of prevalence, screening, and management of bipolar in your patient population. I'm always so grateful to call on my colleague and friend, Dr. Clark, to help answer these questions. Dr. Clark, welcome.
Well, thank you for having me. And I'm a little, hopefully I can be seen clearly.
We can see you clearly. Everything worked out just in time.
Right. Well, wonderful. You know, gotta love technology in the pandemic era.
Absolutely.
But it's a pleasure to be here as always to chat about our favorite topics, mental health in the perinatal period. And I look forward to our discussion tonight.
Absolutely. I mean, we've had glitches. There's always a little bit of a glitch. Last webinar, I couldn't even see myself on my computer screen. So I wasn't able to answer any of the questions or anything. So part of the course, but we're just happy to have these 30 minutes together. And really, the goal is to leave you with a few pearls you can take away and incorporate into your practice. And I will say I've been able to do that with all of our webinars, which I so appreciate. So I've been wanting to talk to you about this topic for a while. It's just been a matter of timing. But how did you first become interested in bipolar disorder in pregnancy?
Honestly, it was in training. I was working with patients who had bipolar disorder and were on the inpatient unit or coming into the outpatient clinic. And because they're pregnant, saw this concern around the medication that they're taking. And I can honestly say my attendings that trained me were not, they weren't, flabbergasted by medication in pregnancy. But when I would go to the literature to get, just guidelines, like, what am I supposed to do with this patient? How does this work? She's complaining of more depressive symptoms. I couldn't find anything. And then I was often, honestly, although you're not one of these OBs, Nas, but I was often going back and forth with the OBs about the best care. And we would really be in these disputes sometimes because my attendings were like, oh yeah, well, just continue the medication. And I would go and see the patient on the unit. And they're, first of all, scared of the patient on the OB unit. And then furthermore, they've stopped all the medications. And I'm saying, could you please put them back on? And they're like, no. And I'm like, but this person is gonna decompensate. And they're like, can you please take her off this unit? I'm like, that's not the answer. So I found myself very intrigued by, how do we best take care of these patients and what can I do to help impact the way or improve upon how we're caring for this patient population. And it's been an ongoing passion of mine because I feel like these patients are the ones where they're being told you can't have a child by some providers. They're being told you can't be treated during pregnancy. And I'm saying, why are we telling these women this,
Yeah, there's so many instances where people treat a pregnant person with a 10-foot pole. And it's just like, because women were excluded from these studies so early on and we can't have any data, it's like we're supposed to stop treating it. And so I tell my patients, if they're ever seeing a doctor who's telling them that they shouldn't be on there
Mhm.
isn't a way to keep them on their medications for their mood condition in pregnancy, they need to switch providers because they're not
Absolutely.
seeing the right person. So
Yes. Like I said, not you, Dr. Nas,
no,
but
but just remembering too, but it really takes changing our mindset
yeah.
um and at least even if we're scared about it, knowing where we can go.
Yeah.
To that point, what has your research focused on to date?
So my research has been mostly focused on understanding the course of illnesses and more particularly understanding the course of illness as it relates to the medications that we use to treat bipolar disorder. So, well, there's a whole host, but which we'll get into a little bit more later. But the what we don't understand about how we use these medications, when it comes to antibiotics or HIV medications for that matter, or diabetes,
Mhm.
like, oh, okay, well, this is how we adjust the dose. This is how we keep women well. This is what's best in pregnancy. When it comes to bipolar disorder, we definitely have made strides in terms of what to continue and feeling comfortable with what are the potential risk factors in terms of congenital malformations or things like that. But when it comes to optimal dosing so that patients stay well, if they do choose to continue their medication, we have no guidelines on that. That's what I've spent the last decade of my career doing, is developing those guidelines for pregnant women. And, thankful to have made some strides in that area that people are using globally, really. But it's hard research because bipolar disorder is not the most common illness, and bipolar disorder with women who want to be who are pregnant, who want to be in part of research, who just all the things to make a steady sample size robust is a little challenging, but I'm still committed to the work because we need to understand how best to treat these women. And with some of the methods I've used, I've been very happy to see how great the outcomes have been.
And hopefully we'll hear more about those outcomes in a little bit. But going back to just understanding it, what should obstetric providers know about bipolar disorder in women and how it might manifest in the prenatal and postpartum period?
Yeah. So what what providers should know, and even family and friends should know, is that bipolar disorder increases the risk of a postpartum depressive episode. So it could look just like major depression that we all seem to understand a lot better than bipolar disorder. It can look like mania, but more often it is the depressive episode that occurs postpartum for women with bipolar disorder. But they're 50% more likely to experience that episode than a woman who doesn't have bipolar disorder, even if they're
Wow.
taking, well, not saying even if they're taking their medications, but maybe just due to the sleep deprivation and other stress factors they're dealing with. Also, they're 100-fold more likely to develop postpartum psychosis, which is a psychiatric emergency and increases the risk of suicide or infanticide. And they're 23-fold more likely to be hospitalized within the first 4 weeks because of their mental illness. So they're really a vulnerable group. And I think providers must know that you can't just look at someone and say, oh, they have bipolar disorder. I mean, I could tell,
Mhm.
because I definitely heard that too. Like, oh, well, we don't see patients like that. Most of my patients that I have seen with bipolar disorder are actually very high functioning. They're doctors, they're lawyers, they're business women and men. Being an expert in this area, I've taken care of a lot of men too. And they're quite high functioning, quite smart, quite intelligent. It doesn't, they don't have a sign that says I have bipolar disorder. So, so definitely those patients that you wouldn't even suspect have this illness and just haven't chosen to share it with you, I think it's so important. That's why we ask about it.
Mhm. And so I just want to highlight those numbers that you provided. So you said there's a 50% increased risk of having a postpartum depressive episode, a
Yeah.
hundredfold more likely risk of having a episode of postpartum psychosis,
Yes.
and 23-fold more likely to be hospitalized in the first 4 weeks postpartum.
Absolutely.
How do you prep for that? So I'm thinking, like, what if when I see patients for preconception visits,
Mhm.
and first, most of the time I have to tease out, like, I ask about medical history and no one says anything. And I say specifically any history of anxiety and depression. And I don't think I ever give more than I leave it like that. But then when I hear about medications, sometimes like I think, oh wait, these aren't your typical regimens. Maybe there's more to it. Oh, you know,
Yeah.
would you recommend, should I be explicit and say, do you have bipolar disorder or
Yeah, I think it's worth being explicit at this point. I think a lot of women still, are dealing with the stigma of having a mental illness, and they're feeling like, well, if you haven't noticed, I don't want to. There's still this idea that it makes them weak, or something like some type of scarlet letter on their forehead. Um,
mm-hmm.
so I think the more you can normalize it and say, hey, have you dealt with depression before? Do you have bipolar disorder, anxiety? It's just like we check off for any other thing, the heart disease, Um,
Mm-hmm.
I think the more we can normalize it, the more likely patients will follow suit and begin to share more. But yeah, they're not. I think a lot of times they're not feeling like, okay, well, you're not the psychiatrist. I don't really have to share this.
Right.
And if they haven't been working with a perinatal psychiatrist, where, I try to empower my patients to talk more about it, to definitely tell their OB-GYN and their pediatrician, if they're breastfeeding. Um, a lot of times they're just, they're ashamed that they're even taking medication. So.
Mm-hmm. And we'll talk about the medications too. In terms of how about if this question just came to mind, if someone has a question about their chance of um, passing this on, is there a genetic component, and do you know it off the top of your head?
I don't know the rate of transfer off the top of my head, but yes, it is a genetic component for sure. And it's not like 100% transfer. I don't want to give a number, put a number in anyone's mind. I have one that's coming to mind, but I want to double check first.
Yeah.
There is a genetic risk for sure, but because it's not 100% transfer, it doesn't mean like, okay, if your mother has bipolar disorder, you'll definitely have it. If anything, and if there's any family mental illness, like mom or dad, it can morph into a lot of different things. It could be mom has depression, but you're born with bipolar disorder. Mom has anxiety,
Mm,
born with depression. So similarly with bipolar disorder, mom could have, or dad could have bipolar disorder, but you have anxiety. So it doesn't have to be the same illness either, but
got it.
but definitely not 100% transfer.
And so how are you screening for bipolar disorder? We've talked about this briefly in our previous webinars, but are there any validated screens and what are their limitations?
Yeah, so the validated screens, or there's really nothing validated, and let me take that back. Nothing really validated in the perinatal period, but validated screens in general for bipolar disorder include the mood disorder questionnaire. Another one I like to use is whiplash, because it gets at some of the nuances, like every time you take an antidepressant, do you get wired and energetic
Mm,
or agitated or something? Things that no, we can dismiss one time, but if it's happening like multiple times, you try antidepressant, red flag. Have you had multiple episodes of postpartum depression? Do you have mood swings that are out of the blue? All of a sudden you're depressed. All of a sudden you're, feeling great. So that's what the whiplash.
hmm.
The mood disorder questionnaire asks, some of the about any history of symptoms. So feeling on top of the world, being very productive for days on end, not needing sleep, along with that productivity, feeling like you're having a racing or flight of ideas, as we call it. Mind is moving faster than you can keep up with, basically. More
Hmm.
impulsive, things like that. So he'll say, have you had several of these symptoms, typically 7 of these symptoms, all at once at any time in your life? So it's a very historical assessment or screen. And You're depending a lot on the inside of the patient, which is what makes these screens difficult, particularly the mood disorder questionnaire, because the patient may, they're like, I mean, there was that time where it's feeling energetic, but I mean, it wasn't a problem,
Mm-hmm.
They're trying to they're trying to guess what you're looking for, and that can be a little challenging. And they may have never just perceived these things or noticed that these things were all happening at the same time.
And got it. And so in your research, when have you found that most women are getting diagnosed with
Yeah.
bipolar disorder
Well,
as a result?
in life, it takes 11 years, honestly. The data shows that it takes 11 years from the first point of contact with the mental health provider for a patient with bipolar disorder that is a woman to be diagnosed correctly. So more often than not, they're diagnosed with depression or anxiety first. They're compared to men, which it takes about 7 years, 7 year delay. Their delay is longer. And part of
Oh,
the explanation for that is that women tend to come in, as do men, when they're feeling depressed. They're not coming in when they're feeling on top of the world, or in hypomanic episodes, honestly, they're not bothersome. The only problem is that they, after that hypomanic episode is over, they might be depressed. So that's when they come in.
got
And
it.
that's one of the things. It's like if someone tells you they've had, I don't know, more episodes of depression than they can count, that's another red flag. You're like, well, how often are you having these depressive episodes? And if it's several a year, then you start to wonder if they're cycling out of a hypomanic episode into a depressive episode multiple times in a year.
So that's not typically what you would see for someone with major depressive disorder?
Not at all.
Oh,
The depressive disorder is more likely to have, assuming untreated or not effectively treated, is more likely to have these long periods of depressive symptoms, or being in that depressive episode. So it could be months. And then they might, doesn't mean they can't come out of it, but they're not as likely to say, oh yeah, I mean, gosh, probably had 8 episodes this year or 10 episodes this year. That would be a red flag for me.
that's great to know. That's, yeah, not something I would ever have thought of. Um, and on that, oh, I was going to say that 11 years you mentioned, I think that's similar to the time it takes for a person to be correctly diagnosed with endometriosis too.
Oh wow.
It takes, from the first point of contact. I think I remember seeing it's, and there's 7 to 8 years where maybe it takes 7 to 8 years to correctly to acknowledge that they're having problematic pain. But then it can take up to 11 years for some women to be diagnosed. So it's fascinating how many of these parallels we have
Yeah, and
when it
and
comes to women's health.
yeah, I was just about to say, when it comes to women's health, it's amazing that we're still struggling.
Lots of catch up to do. So, how do we manage bipolar disorder, and specifically in pregnancy and the postpartum period? What medications are safe to use, and what should we be avoiding?
Yes. So just number one avoidance is Depakote, which I don't, which is it's a great and effective medication for non-pregnant um, patient.
Oh, we lost our speaker. So I'll give her a few seconds. If anyone has any questions while you're hearing the conversation too, feel free to send them in the chat. And while we're waiting for Dr. Clark to join again, I'll actually give some updates to everyone that I was going to save till the end so we can have more time to chat with her. Um, I did want to tell you that some big news on the Seven Sterling side is that we're now seeing patients in Texas, as well as Virginia, Maryland, and DC. And Dr. Clark, I'm giving a few updates while I was waiting for you to log back on.
Um,
And I also wanted to let everyone know, I won't mention this later, but that we now accept most United Healthcare, Anthem, Care First, Blue Cross Blue Shield, and Cigna insurance plans. So for more information, you can respond to the newsletter or email practices@sevenstarling.com. Okay, Dr. Clark, you were talking about avoiding Depakote,
Yeah, so
medications we should absolutely avoid in pregnancy and postpartum.
absolutely. So Depakote being one that I wouldn't give to any person who is of childbearing age, period. Done. Like, as I was
Okay.
a great effective drug for the non-pregnant out of childbearing years or a male. So it's a great drug. But yeah, the risk of congenital malformations, neural tube defects being one of the major ones, as well as IQ um, development and other neurodevelopmental issues, it's not worth the risk at all. And it's a pretty consistent and strong signal, in the studies that have been in the past. So with that said, everything else is fair game, but you're always balancing. I hesitate to use the word safe because none of the medications we use are 100% safe. There's always some risk factor, or they're understudied. We've never randomized them to do a randomized trial to really tease out all the details, but we know enough with many of the medications to know that, okay, well, we don't expect a congenital malformation to happen, but maybe the baby will be large, or we have to look out for you developing gestational diabetes, or things like that. The major medication where we still have some concern about a congenital malformation is lithium, and
Okay.
that sucks because it's the gold standard for the treatment for bipolar disorder. But I use it a lot. I've studied this significantly in my research using lithium and dosing it appropriately. And I thankfully, knock on wood, I haven't seen any bad effects. But with that
Right.
said, cardiac malformations continue to be a concern. Each study that comes out, however, continues to show us more and more that this is less of a risk. The more
Okay.
data out, each number seems to be lower, which is good and that's promising. So I share that with my patients. It's a rare absolute risk of developing a cardiac malformation, and it's very possible that it might, you know, might resolve spontaneously.
Got it. So you're using something like a lithium as a gold standard, and then are you adding anything else to it? Like what's the role of something like a Seroquel or a Haldol? Or some I had a patient I was on call last night with bipolar and she was on Cymbalta.
Mm-hmm.
How would
Yeah.
you think about those medications?
So, I'm always asking, do we need to add something, and have we maximized the medication that we're already using? This goes back to the need for more research and guidelines in this area. So in my research, I've found that lamotrigine and lithium, for example, and even some of the
Hmm.
antipsychotics like quetiapine, um, they they decline in concentration across pregnancy. So what happens is that you might have a patient coming in the second trimester saying, I'm just not doing well. I'm not feeling as good. I'm not, they're trying to tease out whether this is pregnancy or their mood, but they're giving you pretty significant mood complaints. And my first go-to is the medication that they were taking fine before pregnancy. Hopefully that was the case.
Hmm.
So I'm like, okay, well, you did great before pregnancy. The first assumption should be that the medication has dropped in concentration and should go up in dose. So that's the first thing I do. And then from there, if there's still problems despite going up in dose and trying to titrate to a more effective response, then I'll consider adding a medication for those depressive or anxious symptoms. But yeah, that should be like your last resort because you really want to optimize what you're already using to reduce
Got it.
exposure. Yeah.
And then with bipolar, we've talked about with depression and anxiety, therapy is going to be a mainstay. Um, are you also offering that for your bipolar patients? And if they're, what kind of therapy? is more geared for bipolar patients if they're using it?
Yeah, no, therapy is always great. I think dialectical behavioral therapy is a great one. It is commonly associated with borderline personality disorder. I'm not telling the patient with bipolar disorder that that's what they have, although those two disorders can go hand in hand on occasion.
Mm-hmm.
It's really meant for mood regulation. It's not uncommon to have a patient with bipolar disorder where where they're having trouble regulating their mood, or even being insightful to how their mood is dysregulated when they're not, effectively treated, or they're in the midst of having some symptoms. But the
Got
other
it.
one we love is IPSRT, which is interpersonal social rhythms therapy. And that particular therapy, which I think we could all learn something from, um, is really focused on structure and circadian rhythms. So we know that there's been plenty of data to suggest that the circadian clock for the patient with bipolar disorder is slightly altered. So they can be more sensitive to changes in daily rhythms, for instance.
Mm-hmm.
So to give you a couple of examples, the patient who takes a long flight to Europe, they go to Asia or something, the time zone
Mm-hmm.
change, 3 times, and they get off the plane and they become manic. That's not an uncommon scenario. Actually, I've had several patients deal with that. So we start to work on trying to reset their clock before they leave. But it could be simple things that we all deal with every day, like changing a job, moving, trying to meet a deadline, so you stay up late, getting married, getting divorced. Any of those things can be stressors that can be triggering. And the daily stuff of like working hard and staying up late to meet a deadline, that can actually be a big trigger. Have nurses who work the night shift, and that can be a trigger.
Mm-hmm. And I was going to say, so knowing this, how do you prepare that patient that you told about the 23-fold risk of being hospitalized in the first 4 weeks postpartum? How do you prepare them for what their bipolar might look like
Yeah,
postpartum? And how about like, what do you talk about? Breastfeeding, sleep? What
yeah.
should we know?
It's so individually focused. This is where you must really personalize it to your patient, their resources, their circumstances. So for the person who has a mate and that mate is not traveling, or something, um, I'm advising them to split the sleeping time with the mate. It should not be. A lot of women do this. It's like, oh well, I gotta get up every 2 hours because he's working. I can't. Um,
Mm-hmm.
I can't bother him. He needs to get up in the morning. I'm like, no, you're both working. And
Yeah.
so you need to split this time, because otherwise he's going to be there with the baby by himself, or whoever the partner is will be by themselves anyway when you're hospitalized. So
Right.
I talk a lot about consolidating sleep in 4-hour blocks. So pumping before the evening, or even splitting feedings with formula, so that there can be some consolidation of sleep. Of course, it's not going to be perfect, but it's definitely better than every 2 hours, because there's no way to get into REM and actually get some rest.
Mm-hmm.
Of course, if there's opportunities for a night nurse or a doula, absolutely recommend that. If there's family around, friends, siblings,
Mm-hmm.
I
Right.
recommend they, like, hey, just let them know you really need this help. Can they come at different times? Everyone cannot descend upon the patient at the same time, but have them pick some weeks and early on to help overnight. And so, yeah, and I think there needs to be more resources for this, because everyone doesn't have the resources I just mentioned. Everyone isn't privileged in that way. There are some home visit programs in, I think, all 50 states. So, uh,
Mm.
for the patient who is lower income, and they're not necessarily, staying with them overnight, but those can be effective programs at least to help out.
Are you thinking like, do patients often need adjustments in their medications in that immediate postpartum period?
Yeah, they do sometimes, depending on the medication. So quetiapine, for instance, we use it for sleep these days. We use it for
Mm-hmm.
bipolar disorder. We use it to help with depression. But because it is a very sedating medication for the patient who is newly postpartum with a newborn who's already struggling to get up and sleep and all of that, that medication, for some women that can't tolerate it postpartum, they absolutely are like, I can't wake up to do any feeds for the baby. So
Mm-hmm.
sometimes they'll have to go down on medication or switch medication to meet their needs. But lamotrigine, lithium, most of those, if you had to titrate it up in pregnancy, you have to bring it back down immediately postpartum. Otherwise, those medications are fine. They're fine to breastfeed on. There is some dispute in the field, just a little caveat on lithium and breastfeeding. I personally recommend it. I got
Mm-hmm.
out there to tell you otherwise.
I was going to tell everyone, hopefully you're all familiar with mothertobaby.org. That's mother and then TO baby.org, because they have fact sheets that are fantastic for patients who are looking for medication safety. And then if the medication's not listed, you can have a live chat with an individual who will at least give you some information. And I think it's, especially for my patients who are coming in with SSRIs and have questions, they really break it down well with the studies, the risk of miscarriage, congenital malformations. So just something for people to know about. Well,
Yeah.
and Dr. Clark, just really quickly, because I know it's 6:02, for that postpartum patient, are you telling them to check in with their psychiatrist more frequently? Like, I see my patients at 6 weeks if they've had a vaginal delivery, 2 weeks if they had a C-section, and then 6 weeks. So how should I be telling them to engage with their other support
I
members?
definitely advise my patients that I'm aware of prior to delivery to come in 3 weeks postpartum, particularly
Okay.
bipolar disorder who is high risk for having a relapse postpartum. 3 weeks, the reason being is that the first 2 weeks could easily be postpartum blues. And so I don't want to be trying to tease out if this is this postpartum blues or is this an episode? At 3 weeks, if they're not doing well, then that's, a reason for me to move forward with changing the medication or making some adjustments. So 3 weeks, and then every month after that, depending on how well they're doing, more frequent if they're not doing well. I
Got
don't
it.
I don't really go past 6 weeks, 6 week segments even if they are doing well.
Thank you, Dr. Clark. Thank you for all of this amazing information. I know we could talk about this more because you have so much to offer on this topic, but we want everyone to be able to get back to their lives, and just you got the 101, I think, hopefully tonight, of what you need to know for so bipolar disorder. We mentioned psychosis in the perinatal and postpartum period. At Seven Starling, we are also, I wanted to let people know who are OB-GYNs. We're starting a national provider council of OB-GYNs who are passionate about improving women's mental health and want to do so from their offices. So this group will convene monthly and provide us with insights on how to improve our services as we expand. The role is compensated, and I'll drop the link in the chat in case anyone is interested in sharing it with any colleagues you have, or wants to apply. At Seven Starling, we are committed to providing the full spectrum of women's mental health care and would love to support you and your patients. Please check out our website, sevenstarling.com, to learn more about how we may help you in your own practice. If you like this webinar, please subscribe to our newsletter so we can keep you informed about future events. Dr. Clark and I will be meeting. Hopefully, we'll have a topic for March or April to talk about. And if you have any suggestions of topics you want to learn about, send them my way at nazanin@sevenstarling.com. Dr. Clark, have a wonderful evening. Thanks again.
All right. Thank you for having me. As always, you have a wonderful evening as well.
You too. Bye.